Hello, everyone, and welcome to this RPTH Research Recap on World Hemophilia Day, where we dive a little deeper into the science that's being published at RPTH. My name is Ming Lim, and I'm an adult classical hematologist with a focus on hemostasis and thrombosis at the University of Utah in the United States. Thank you all for joining. I am very pleased today to introduce to you Dr. Flora van Leeuwen. Dr. van Leeuwen obtained her medical degree from Utrecht University, I probably mispronounced that, in 2020. And thereafter, she started as a PhD candidate at the radiology department of the University Medical Center of Utrecht in Netherlands. Her research is in collaboration with the Hemophilia Treatment Center at the university where she's at and focuses on imaging of subclinical joint changes in hemophilia. Currently, Flora is working as a radiology resident in training at the Meander Medical Center in the Netherlands, and she recently published a paper in RPTH that's titled Ultrasound in Addition to Clinical Assessment of Acute Musculoskeletal Complaints in Bleeding Disorders, Impact on Patient Management. So the use of point-of-care ultrasound is becoming very widespread in all fields of medicine, and particularly for our patients with inherited bleeding disorders, musculoskeletal ultrasound can be used to evaluate joint health in hemophilia care. Ultrasound is a fast, non-invasive, and relatively inexpensive and accurate modality to assess blood-related changes in the musculoskeletal system with very good reproducibility. More importantly, in a clinical aspect, it can also be used in acute setting to detect joint bleeds. However, given that formalized training for musculoskeletal ultrasound is required and the cost of ultrasound machines may be cost prohibitive, the addition of such measures, in addition to conventional physical examination, needs to impact diagnosis and treatment in individuals with hemophilia by possibly reducing underdiagnosis and overtreatment. And so this paper by Dr. van Leeuwen is a timely article. For those joining us live, please leave your comments, which will be answered during the discussion. And Dr. van Leeuwen, we really look forward to hearing your presentation.
Thank you, Dr. Lim, for the introduction. I'll share my presentation. So in the next 10 to 15 minutes, I will share the results of our recent study on the impact of ultrasound added to clinical assessment for the diagnosis and treatment of acute musculoskeletal complaints in bleeding disorders. So musculoskeletal bleeding is the hallmark of hemophilia, as Dr. Lim already introduced, but it also occurs to a lesser extent in people with von Willebrand's disease. If bleeds occur repeatedly or treated poorly, this can lead to complications such as hemophilic arthropathy in joints and compartment syndrome and muscle necrosis in muscles. Therefore, it's important to diagnose those bleeds at an early stage, and that's usually done by clinical assessment, by symptoms such as pain, swelling, and reduced range of motion. However, those symptoms are not specific for bleeding, and they can occur in other MSK diagnoses as well, especially when a patient has hemophilic arthropathy. It can be very difficult to distinguish a joint bleed from an arthropathy flare-up, and therefore ultrasound is increasingly used. There are previous studies, one from San Diego, one from Spain, and one from Uruguay, who already investigated the value of ultrasound for diagnosis of joint bleeding. And those studies show that ultrasound findings can change the diagnosis in 16 to 65% of the episodes, so that there's a value of ultrasound. However, those studies were performed in adult patients with mostly severe hemophilia, and the majority of the joints included were arthropathic joints. So therefore, we wondered whether those results also apply to a more heterogeneous study population, which is more comparable to the clinical practice. And that's why we conducted our study, in which we looked into the impact of ultrasound added to clinical assessment for the diagnosis and treatment of acute musculoskeletal episodes in children and adults with hemophilia and von Willebrand's disease. We performed a cross-sectional study from March 2020 to May 2023, in which we included patients with hemophilia or von Willebrand disease of all ages and all severities who visited our outpatient clinic of the Hemophilia Treatment Center with acute musculoskeletal complaints that were present for less than a week. At the outpatient clinic, they were first assessed by one of the physicians, and the physician performed clinical evaluation, after which an initial diagnosis and treatment plan was made. After that, one of our two physiotherapists who were trained in point-of-care ultrasound performed ultrasound, and after ultrasound, a final diagnosis and treatment plan was made. We then looked into the differences between the diagnosis and treatment plan before and after ultrasound, and calculated the percentage of episodes in which the diagnosis or treatment changed. And we also calculated the number needed to scan, which is the number of patients that you need to scan in order to change the diagnosis or treatment for one patient. Our study population consisted of 67 patients, all but one were male, and it was a combination of children and adults with a median age of 24 years. Most of the patients had hemophilia, 39% had severe hemophilia, and a little less than half of the patients were on prophylactic treatment. Those 67 patients contributed 77 episodes, which means that some patients were included multiple times. Most episodes occurred in the legs and were due to trauma. Most 55% of the episodes occurred in healthy joints, 24% in arthropathic joints, and 14% in muscles. If we then look into the diagnostic impact of ultrasound, we see a summary in this figure. Let me get the laser pointer. Here in this column, you see the initial diagnosis that was based on the clinical assessment alone, and then you see that 37 joint bleeds were initially suspected, 30 muscle bleeds, and 27 other diagnoses. Here on the other side of the figure, you see the final diagnosis after ultrasound, which were 33 joint bleeds, 11 muscle bleeds, and 33 other diagnoses. As you can see, there were quite some changes between the diagnosis before and after ultrasound. For example, there were 12 joint bleeds and 3 muscle bleeds that were suspected based on the clinical assessment but were not confirmed by the ultrasound. You can also see that 1 muscle bleed and 1 joint bleed were misclassified based on the clinical assessment. And lastly, you can see that in total 9 episodes, the ultrasound showed a joint bleed that was missed based on clinical assessment alone. So to summarize, in 36% of the episodes, the ultrasound findings changed the diagnosis, and that means that the number needed to scan for a change in diagnosis is 3 patients. If we then go on to the therapeutic impact, we see this summarizing figure in which we first see the amount of episodes in which some sort of change was made to the treatment plan after the ultrasound, and that was in 39% of the cases. And then in this part of the graph, you see what kind of changes were made. Mostly Those were changes to the clotting factor regimen or the follow-up, and as a third, the mobilization advice changed quite frequently. And if we summarize this, we saw that in 39% of the episodes, there was some sort of change in the treatment plan after the ultrasound was performed, and that also corresponds to a number needed to scan of 3 patients. To illustrate those numbers a little further, I would like to share 2 example cases with you. The first one is a traumatic episode in the ankle of a 10-year-old boy with severe hemophilia A who was on prophylaxis. He presented himself with pain on weight bearing and on movement. He had normal range of motion and normal gait, and he said that his pain decreased after the use of clotting factor concentrate. He had no pain at rest or during sleep, and at physical examination, his ankle looked normal. He was clinically suspected of ligament injury. However, the ultrasound showed complex fusion, as you can see in the figure on the bottom of the slide. So the final diagnosis in this case was a joint bleed. So this example case is a good example of a missed joint bleed based on clinical assessment alone. Then the next case that I'd like to share with you is also a traumatic ankle episode, this time in a 16-year-old boy with moderate hemophilia A that was treated on demand. And he presented himself with pain on weight bearing and on movement as well. He had a limited range of motion and an asymmetric gait. His pain decreased with motion, but also after the use of clotting factor concentrate. He had no pain at rest or during sleep. And at physical examination, his ankle was diffusely swollen, but had a normal color and a normal temperature. Based on the clinical assessment, this boy was suspected of joint bleeding, but then the ultrasound didn't show any effusion. So therefore, the final diagnosis was ligament injury in this case. So this is an example of overtreatment based on clinical assessment alone. And that already brings me to my conclusion, which is that in people with hemophilia and von Willebrand's disease who experience acute musculoskeletal symptoms, ultrasound helps to diagnose or rule out bleeds, and ultrasound findings have impact on treatment. In our case, the number needed to scan was 3 patients. And that was what I wanted to share with you today. Now I would be happy to answer any questions.
Thank you so much, Dr. Von Leeuwen, for that great presentation. We are open for questions from our audience. Please put them in the Q&A or comment section. And while we wait for questions to come in, I have a few thoughts and comments. As I said earlier, I am an adult classical hematologist, so I see a lot of adult individuals with hemophilia, and some of them have a lot of joint issues, and there's always this dilemma on whether when they're experiencing pain and swelling, as you showed in your 2 examples, whether it is truly a bleed or whether it's a ligament issue or a joint issue. And so in that really wonderful diagram, figure that you showed earlier, where you showed what was the diagnosis pre and what was the diagnosis post, there were, as you mentioned, 12 individuals who were initially diagnosed with a joint bleed based on clinical symptoms, but were ultimately given a different diagnosis of other. Are you able to share what was the other diagnosis that was eventually made? I guess one of them is ligament issues.
Yeah, certainly. And so, yeah, you're right. In the majority of those cases, I guess it was eight of the 12 episodes, the final diagnosis was ligament injury. And so if you look at the other group in which joint bleeds were missed, you see a similar thing, but then the other way around. So most of the clinically missed joint bleeds were initially diagnosed as ligament injury, but then later turned out to be bleeds. So it's interchangeably.
Mm-hmm. And then as a follow-up question to that, I believe in your protocol, you gave a leeway of 7 days from the time that an individual presents with symptoms of possibly a bleed. They had 7 days to come in for a musculoskeletal joint evaluation with ultrasound. Do you? And then again, I guess depending on individuals, some of them may have infused factor beforehand, like the example you showed in the second case. Do you think the infusion of factor, just say at day 1 and day 2, would have impacted the joint evaluation at day 6 and 7?
Yeah, well, there might be an influence, but I guess that in our study population, this influence was small because there was a maximum time window of 7 days in which the patient could present themselves, but most of them did within 3 days. And as a little bit more than half of the population wasn't on prophylactic treatment, they actually had to come into the HTC to receive their trauma doses because they don't have that at home. So the proportion of patients that were pre-treated, as you can say, wasn't that big. But yeah, it could have had an influence. But still, I guess, even in patients that already self-infused clotting factor treatment, the ultrasound can be useful because if you then don't see a bleed on your ultrasound, it can be a reason to terminate the clotting factor treatment at an earlier moment than you would without the ultrasound.
Okay. Thank you for that. And we have quite a few comments coming in. And so the first comment is, do you think that the results depends on the experience of the ultrasound operator?
Well, if ultrasound is a operator-dependent modality, so especially the quality of the images, I guess, will depend on the experience of the operator. The diagnosis of a joint bleed, not so much, I guess, because a fusion is quite easy, at least for me, to see on the images, but it really depends on the quality of the image, and that can sometimes be difficult with less experienced operators.
Got it. Okay. And then for our next comment, do you think this could apply to adults as well? And what about the use of the Doppler mode? Do you think it can provide more information about the bleed?
So the first part of the question, if it applies to adults as well, yeah, certainly, because still about half of the population, or even more than half of our population, were adults, so yes. And what about the use of the Doppler mode? I think it can especially help in differentiating between a joint bleed and synovitis. Well, that's at least where for what we use the Doppler. So it can provide some information, but for differentiation between a bleed and no bleed, I think just the gray mode images are most important, but it certainly has yields extra information.
Okay. And then one more comment that just came in. It mentions that you use 2 different types of ultrasound machine, and was there any difference in the performance between them? And do you have any experience with using the small portable point-of-care ultrasound that's currently available? I personally have used the Butterfly myself, but I would love to hear your comments.
Yeah, so we use 2 different ultrasound machines, one older model and a newer one, and we didn't really see any difference in the performance or diagnostic performance. And at our center, we don't have experience with the small portable ones. So yeah, can't really comment on that.
Okay. As we wait for more comments to come in, if not, I just want to ask from a clinical perspective. For instance, the 12 individuals that they thought they had a bleed, and I assume they treated because that's what we tell them to do. If you think you have a bleed, you treat. The fact that they ended up not being a bleed, do you think that would impact their management moving forward? Like in the future, they might think, I had an ultrasound, it wasn't a bleed, I'm having the same symptoms. Do you think it impacted their own self-management of the pain, swelling, decreased range of motion that they're experiencing?
I don't think right away, because that's what we see in literature, but also what patients experience. The symptoms are quite non-specific. So one time it can be a bleed, but the other time the same symptoms can be something else. So I don't think it will change their management right away. And I would also say that's not justified. But what we saw in our patients, what we didn't measure, but what we experienced, is that they also themselves experienced the value of the ultrasound, and now they tend to contact or come in to the HCC more often if they are unsure, or whether they or if they want to know for sure whether it's a bleed or not. They tend to come in more often for the ultrasound. So we experienced that our patients really value the ultrasound as well.
Okay. All right. So thank you very much, Dr. Van Leeuwen, for presenting your work and giving us more insight into how the use of point-of-care muscular ultrasound has impacted your patient management. We hope that the viewers will read the full details of your paper on the site, the rpthjournal.org. And Dr. Van Leeuwen, I hope you will publish again in RPTH. So thank you for those joining us live. And don't forget to follow us on Facebook, LinkedIn, Twitter, X, and YouTube. And thank you for watching, and keep an eye out for the next RPTH recap.